Hey, I'm Dr. Joe Niamtu, LoveThatFace.com. I'm a cosmetic facial surgeon in Richmond, Virginia. I do surgery from here to here. I don't do boobs, bellies, or butts. I'm a surgeon, a teacher, and an author. And today, we're going to talk a little bit about deep plane face and neck lift. I'm going to show you an actual video of the procedure. So I have about 600 YouTube videos, and I talk to viewers every day from all over the world. It's been an amazing experience. And somebody asked me to post actual surgical footage of an entire operation. So that's what we're going to see here. Just a little history. Deep plane face and neck lift, although it draws so much attention, it's not a new procedure. Sam Hammer was one of the first people to develop this in the 1980s. And for many years, I was on the faculty in St. Louis at Mike Nyack's facelift course. And we had a great time up there, did a lot of teaching and a lot of learning. And Tim Martin, a very well-known plastic surgeon from San Francisco, came and gave lectures and cadaver demonstrations on deep plane face and neck lift. And I really think that was ground zero for many of this. And this was, it might have been as early as 2008. I can't remember exactly. And of course, as you know, my buddy Mike Nyack took off with that to the top of the heap. And I've learned so much from Mike over the years. We're good friends, our families vacation together, and just one of the many people that I love being around. So I'm going to show you this video, and I hope you enjoy it. I'm Dr. Joe Niamtu, LoveThatFace.com. Okay, we're going to talk about marking the deep plane facelift patient. Of course, a sideburn incision, which we hyperbevel with the scalpel later. I call it the tri-arcuate incision to make 3 distinct arcs, because that's what the junction of the cheek and the ear is. In the sulcus in the back to the greatest width of the pinna, and then either back into the hairline or the occipital hairline, whichever you prefer. And I always like to mark the jowl because I frequently do some liposuction on there. And I mark Petange's line, which goes from the attachment of the earlobe to 15 millimeters above the eyebrow and is the approximate course of the facial nerve as it crosses the zygomatic arch. And then the extent of the skin dissection is marked from the lateral orbital rim to the mandibular angle. And that's going to be a very small skin dissection comparatively to other style facelifts. And then mapping out whichever SMAS entry that you prefer. And I take this down to about the level of the hyoid. It's going to be subplatysmal dissection inferior to the angle of the mandible. And that's basically the dissection. Of course, the submental dissection. Better go back and draw a better line than that, Joe. And once again, this is a more conservative situation than previous facelifts where you're dissecting way inferior on the neck, sometimes down almost to the sternal notch. We use a 500 ml bag with 1/2 gram of lidocaine, 1/2 gram of epinephrine 1 to 1,000, and 1/2 gram of tranexamic acid. And for the traditional deep plane facelift, and that's what we're going to talk about right now, the contemporary deep plane facelift, your skin undermining is much less all the way around. So it doesn't take as much tumescent anesthesia. And again, we have a large SMAS flap and a small skin flap. So I am injecting So we make our submental incision and begin our dissection, subcutaneous, and I try to leave as much fat as I can on this flap. We'll need it for insulation and to hide any deeper irregularities. Now, if you're doing the so-called preservation technique, you're not extending your subcutaneous dissection all the way to the postauricular dissection. You're leaving a patch of undissected subcutaneous regions, and you're going to do that subplatysma, as I'm showing here. And this has been popularized by my good friend Mike Nyack, and we're going to go subplatysmal there, and we'll be pulling the skin with the deep platysma as opposed to traditional dissection where we used to undermine all the skin. Then we're making a midline incision here. You can use whatever instrument you want. This is a Sonoquence radio wave radio frequency device, and I'm dissecting subplatysmal now, and we're going to dissect laterally for about 4 centimeters. And during this dissection, you will frequently uncover the submandibular gland, especially if it's ptotic. And so dissecting subplatysmal laterally, and I've also completed that on the other side. Now, if you're going to be reducing the digastric muscle, you can do it at this point. If you're going to be reducing submandibular gland, it does help to reduce the muscle. It increases your vision. And if you're I said increasing the muscle, I meant incising the muscle. If you are reducing the digastrics and reducing subplatysmal fat, but not taking out submandibular glands, that can be a problem. So there's the platysma, and there is the gland in the inferior lateral part of the dissection. And this is a very big and very ptotic gland. And we are going to be reducing just the superficial lobe. The deep lobe curves back under the mylohyoid, and in the deeper lobe, that's where you have the hypoglossal and lingual nerves. So we want to stay inside the capsule. Intracapsular dissection is safe with submandibular gland reduction because the marginal mandibular nerve runs about 3.7 centimeters superior to the gland by the inferior border of the mandible, as we know. I inject regular 2% xylocaine with 100,000 epinephrine and let that sit for a little bit to work. There's a lot of ways you can do this. I'm grasping the base with a tonsil clamp and cutting across, and then taking off separate lobes. You invite bleeding when you do a cross cut like that. As I'll show you later, I prefer to reduce various separate lobes. This thing almost looks like a cauliflower, and when you take off the individual lobes, you have better control of any bleeding, which I've got a pretty good little pumper there, and I'm using the Sonoquence bipolar to control that. I don't usually inject Botox in the glands, but I have on occasion, and this is the specimen in that particular gland. So sometimes there's capsule or layers to close, and sometimes there isn't. Then going back to your platysma, we're removing any excess overlap in the midline, but leaving enough platysma where it can lay down and adapt to the contour of the neck. So placing 2O vicryl sutures to just past the level of the hyoid, and just doing a little dissection for the mandibular ligament, or so-called mandibular ligament. Now going to our incision. Again, I like this triarcuate incision. You will never ever blunt a tragus, and even the best surgeons can experience a blunted tragus because of remodeling with a post-auricular incision. But I see what the patient wants to do, and I discuss it with them. Our post-auricular incision in a routine fashion, and in this particular case, I'm going into the hairline. If you came to my office tomorrow, you would see me probably do an occipital hairline incision using the Sonoquence micro needle. And again, doesn't matter, scissors, scalpel, bovie, whatever you like to use, and beginning dissection of the skin flap in a subcutaneous manner. And then we're going to dissect. I'm using the scissor to dissect to my line previously made, which is going to be the extent of the skin dissection. Now here I need to go subplatysmal, okay? because we're going to leave that patch and let it attach to the skin and let that patch hoist the skin. For my SMAS entry, I using again, the Sonoquence micro needle and obeying Patange's line, especially when it crosses the zygomatic arch, which I'm anterior to, and dissecting. You can see the parotomasteric fascia and translucent and some parotid under that. Obviously, you want to stay above that area. And at the angle of the mandible, we're going to go subplatysmal, which we'll come back and do. And just continuing my dissection anteriorly. The SMAS is very fixed over the parotid, and once you get into the so-called zone 4, where you have your loose areolar tissue and your attaching ligaments, it becomes much more easily dissected. And so the harder dissection is over the parotid gland, with care not to get into the parotid where you set yourself up for a sialocele. And once again here, transitioning to a subplatysmal plane in that area at the angle here. So once I am over the fixated tissue on the parotid, then it's a lot easier to dissect that SMAS. And this is the zygomatic ligament in this area. And different people use different SMAS entry points. I don't think it matters that much for your deep plane entry point. And once you get into this zone 4, then you can use various types of dissectors. Actually, I prefer the Viterbo dissector, which I use now. And if you're doing a true deep plane technique, you're dissecting to the lateral nose and to the nasolabial fold and to the modiolus, which I'll show on this side. So that's my deep plane dissection. And I leave these little perforators there. Some of them can be contain nerves. And once again, I'm extending my finger to the modiolus, complete dissection, subSMAS there, to the nasolabial fold. And here is my subplatysmal dissection, leaving that preservation patch, which I don't always do, but I think it makes some sense where you're having your SMAS retract your skin. So once again, everything is freed up to the mid-face. And you don't want to dissect too anterior in this region because of the marginal mandibular nerve. But I'm undermining that patch, which they call Rothsky's patch. And now my SMAS is mobilized. Again, to the lateral nose, the nasolabial fold, the modiolus, and subplatysmal below the angle. And you can see the effect of retracting this tissue when it's attached. So here I'm trimming the excess SMAS for an end-to-end closure. And I'm going to do a little transposition flap here, which I don't always do. I did it here to demonstrate this, where I think that further really defines your mandibular border in some cases if you have a thick enough SMAS. And now my SMAS closure, once again, using 2-0 vicryl suture. And I tend to put a lot of sutures in from the orbicularis region all the way down to the hyoid. And I probably usually do a suborbicularis dissection. I don't really pay that much attention to it, but I'm under the SMAS, which that means if you're really under that layer, you're under the orbicularis and you're under the platysma in the true deep plane situation. And once again, just showing the transposition flap, debulking that. And so all of my SMAS sutures are set. And once they're set, then you can close this entire situation without tension. Here I'm putting key sutures in, but you're closing without tension because the SMAS bears the tension because it's a deep plane. And otherwise, you're trimming skin. Notice that your skin excess is much, much less than your traditional facelifts, which sometimes cover the whole ear. So, it's in some respects, it's half the work, twice the result, some people will say, but definitely smaller skin dissection and definitely smaller skin excess and flap trimming. In the anterior, I'm doing a cutback slightly below and slightly above the tragus in the little recess that's naturally there, and securing that with a, in this case, a 5/0 gut suture. And I will do that both above and below the tragus, and then using, capitalizing on the curve of the facelift scissors, cutting off that excess, and with experience you can get that so it almost looks like you don't even need a stitch. So getting that nice edge-to-edge contour, maintaining that tri-arcuate formation. Here I am beveling with the Sonequence micro needle, removing my skin excess, trying to make a reciprocal bevel. I'm going to show just another case and using the radio wave micro needle for my subcutaneous dissections, staying above the parotomasteric fascia. This is my SMAS incision, making sure to stay clear of the facial nerve, and dissecting the fixed SMAS over the parotid. And I'm going to transition to subplatysmal at the angle of the mandible, then get into zone 4, which dissects much more easily, and careful dissection there with the scissor, which is pretty easy in this area until you run into like the zygomatic ligament or some of the other ligaments. Then you have to separate them using a Trepsat elevator here and dissecting. There is the zygomatic ligament, which you want to do that. You want to transect that close to the underside of the flap, and then taking this out to the mid-face structures, the modiole. I'm going to further illustrate the SMAS entry point. That's my subplatysmal dissection, or my low sub-SMAS entry point under the patch that I showed earlier. And this is my suborbicularis superior entry point. And you can enter both those areas, and then you have the section in the center, which is the zygomatic ligament and associated tissues. So once you establish both those entry points, you can dissect sub-SMAS to the anterior face. And this is a way that a lot of people do it. And again, dissecting sub-SMAS to the modiolus. And then that sub-SMAS dissection will also continue to the nasolabial fold. And that sub-SMAS dissection will also continue to the lateral nose. So in a true deep plane technique, this is what you're seeing. And now you have your SMAS once again, and you can control the entire face. I know I'm kind of wearing this out, but I see some people claim they do deep plane facelift, and they're really not very far under the SMAS anteriorly. And to really separate the zygomatic cutaneous ligament and the other ligaments, you really have to be out to the center of the face. There's my subplatysmal dissection. I'm actually elevating the platysma right there. So that's the platysma on the top. And now I'm securing the SMAS. So this is showing suborbicularis oculi dissection, and it got a little deep there. That's probably part of the zygomaticus major, but the patient had no deficit or problem. And here I am under the platysma, so the roof of what the retractor is holding up is the platysma. So subplatysma, subsmass, suborbicularis, you're mobilizing the entire sheet of deep plane facial tissue, and that is the beauty of this procedure. I really like showing the sub-SMAS dissection. Once again, I know it's repetitive, but I think this is the crux of deep plane face and neck lift, where you're dissecting to the malleolus, the nasolabial fold, and the lateral nose to have that complete sub-SMAS mobilization. I think it's integral. And so I'm going to get to the submandibular gland reduction here in a second, and that'll be the rest of the lecture. But right now I'm just showing you all my SMAS sutures and how I manage the skin, putting in key sutures as we normally do, except remember there's really no tension here on the deep plane lift because your SMAS bears the tension. Some people use fibrin glue. I don't. And I use 4-0 Vicryl or 4-0 nylon for my key sutures. And once again, I am showing the skin management here, putting little retaining sutures above and below the tragus at the little recess, just to secure this so I can trim it with a scissor, and using the curved part of the scissor to get a really nice, tight, precise cut there. And all that fits together beautifully. Someday I just would like to try and do it with tissue glue instead of putting sutures in because it's so well adapted. I am trimming the sideburn here. Unfortunately, my staff is not following the camera, but trimming that with the Sonequence micro needle. Usually close that with 5-0 gut or 5-0 nylon for my out-of-town patients, which is about 50% of my practice. So I don't use staples on them unless they can stay long enough. And once again, just working out the little dog ear that you frequently get in the anterior portion of the sideburn. So that'll close without any dog ear, and very passive. Wiping off the char if I'm using electricity to trim the flap so there's no tattooing. And again, closing with a Vicryl suture. I do set the earlobe with a 4-0 Vicryl suture, sometimes two of them, because patients always find ways to separate that. So I like a nice tight closure there. Posteriorly, putting in my key suture, again with little or no tension. And look at the small amount of skin excess we have with the deep plane. That's really a benefit. When I used to do my other types of facelifts, I would have so much skin and so much flap to trim, and so much undermining, which led to more seromas and hematoma. So the small tissue, soft tissue dissection, small subcutaneous skin dissections, what I'm trying to say is really a benefit of deep plane. So once again, just trimming my skin excess. I know this is kind of boring, but I'm supposed to show my technique, and that's what I'm doing. And you notice I wipe that char with a wet Q-tip every time we make an incision, so we don't have any tattooing. And I just keep working this flap. And these are 4-0 gut sutures. I know a lot of you people watching this have a lot of out-of-town patients. I'd be interested to discuss how you manage your sutures and follow-up care. Luckily, we have all of us that are in this room have a wide network of friends that we can call on in other cities if we need somebody have a suture removed or to be looked at for any given reason. So there is my hairline incision, my occipital hairline. And again, we have not lost any hair there, and that should lie passive. So I think you get the idea how I manage the skin. I think this is the most boring part, but it's done here, and we'll get on to the submandibular gland. So if you're a surgeon and you like what you saw here, I have a full online for purchase video series on my website, lovethatface.com, under physician education, or you can get there by going to cosmeticsurgeryeducation.com. And I have all 4K video of all the common cosmetic facial procedures recorded and narrated, similar to what you have just seen. So if you're interested, take a look at that. And we also have a course each year at our office in March, and that information is on the same websites. I'm Dr. Joe Niamtu, lovethatface.com.